This quick PowerPoint demonstrates subpectoral plexus evaluation with sonography, as well as a patient case. As a reminder, the pectoralis minor muscle originates at the medial aspect of the coracoid process to about the mid-clavicular region to ribs 3, 4, and 5. The transducer is placed in a long axis view, starting with the bony prominence of the coracoid and moving inferiorly to see the layers of muscle. In these pictures, the pectoralis major muscle has been removed. Lateral to the pec minor muscle and inferiorly, you can see the serratus anterior muscle, and medially, what you'll see are the intercostal muscles in between the ribs. In long axis view, the left side is proximal. You will see these layers: the pec major muscle, pec minor muscle, the axillary artery, and around it the cords with, at the inferior portion, the posterior cord. To the left side is the lateral cord, and the medial cord is to the right. This long axis video demonstrates the pec major muscle on the top, pec minor, and then the pulsing axillary artery. What can be seen between the major and minor muscles is the neurovascular bundle. The transducer is then placed horizontally to show similar layers, including subcutaneous, pectoralis major, pec minor, and to the left side, the serratus anterior muscle, the bony shadow of a rib, and then intercostal muscles. Just below that, the white line is pleura. This is a patient example of a patient having recurrent pain status post partial pec minor release, as well as injection with botulinum toxin. Thickness measurement of the pec minor muscle on the left side compared to the affected side on the right side, status post Botox injections, as well as partial release, reveal very close thickness with 0.75 centimeters on the left and 0.71 centimeters on the right. Long axis view is performed in the lateral aspect of the pec minor muscle, just above the axillary artery. Going back to long axis view and starting in the inferior aspect of the pec minor, the transducer is moved from lateral and inferior to medial, showing first hyperechoic atrophic muscle and then thick hypoechoic normal appearing muscle. Long axis view is then performed moving from cranial to inferior, and it shows the normal hypoechoic muscle becoming hyperechoic, suggesting atrophy. Review of the musculoskeletal ultrasound reveals atrophy in the lower lateral aspect of the pec minor. The goal was to target the thickened area of muscle with botulinum toxin under ultrasound guidance. This is a cross-sectional view with the left side being lateral, showing an area of hypoechoic muscle that would be targeted by the needle. Between the pec major and minor, neurovascular bundle can be seen. Again, in cross-sectional view, the needle can be seen from the left side of the screen into the pec minor muscle, passing just lateral to the neurovascular bundle. This video demonstrates satisfactory needle placement along with placement of botulinum toxin, noted by the hyperechoic fluid-like passage.